This
Let's start.
conference will now be recorded.
So today we are going to cover 8 modules of the MRCOG 3 syllabus. The topic is management of delivery. This is the module, and as we know that in 2019, RCOG made several changes to its curriculum, and ever since from July this practice was started, and after that we have modified all areas courses according to the new guidelines. Because if you remember, I told you that they are going to test both technical skills and non-technical skills equally. In order to pass exam, you should know about the new requirements and you should practice according to new criteria. The overall number of stations and the domains, that we have got 5 domains and tasks, they will be the same. Okay, but the methods of assessment, they will change a little bit. They expect a bit more from you because communication skill should be much better, and then how you are going through the system, that's very important. So it is more important for those people who are working outside UK. But don't worry, we have evolved a very simple way of dealing with all of these conditions, so you don't have to worry about that. So RCOG says, I will just take like 10 minutes and then we will practice with the stations actively. And that in case of this competencies in place, RCOG says that regarding management of delivery, we can describe it like this, that the doctor is able to apply medical knowledge, clinical skill, and professional values for the provision of high quality, safe, patient-centered care. Now, patient is this focus of attention all the time. Patient safety is one issue which you should not even think about ignoring that. I have seen excellent candidates failing because they didn't observe patient safety. The doctor takes an active role in helping self and others to develop himself and to keep everyone safe. And the doctor is competent in recognizing, assessing, and managing emergencies in obstetrics. Then another point I wanted to highlight here, as you remember, we talked about labor in the previous module. Today we are going to talk about management of delivery, and in the next session we are going to talk about postpartum and neonatal issues. They are the three cannot be combined in one module because you are going to get separate station covering each of these modules. So very important for you to know the differences between all of them. So as a Part 3 candidate, you are required to demonstrate your eligibility to demonstrate certain aspects of practical skill relating to normal and abnormal delivery and their communication to the patients under challenging condition. Regarding that, you should have detailed knowledge requirements. You should know about normal vaginal delivery, operative vaginal delivery, complex vaginal delivery, and retained placenta, management of female genital mutilation, malpresentation, which can be like bra presentation, face, shoulder, variable lie, then as you know, breech presentation, malpositions like breech, transverse, oblique. You should know that how you can do this manual rotation of the fetal head. You should know about using outlet forceps, ventouse, mid-cavity forceps or ventouse, and then rotational forceps. And can we use ventouse to correct malpositioning? You should be familiar with pelvic floor anatomy, episiotomy, perineal trauma and repair, but much of this will be covered in the postpartum care. Female genital mutilation, the types, they can ask you about that, but that will not be a full station. It will be part of a station. Assisted breech delivery, breech extraction, twin delivery, high order multiple births, shoulder dystocia, cesarean section. You should know about indications for and complications of cesarean section. You should know about routine procedure, repeat cesarean section, acute emergencies, sterilization procedures, and very important for you to know that what are the complications of late second stage cesarean section. As active participants, as active residents or specialists, you are familiar with this condition, that how disastrous it can be. So how you can minimize the risk and how you can minimize the damage. You should know about that, how you can reduce the rate, how you can avoid having complications intra surgery, intra procedure, and then immediately after procedure. So you will have to make a holistic plan for management of such patients. But that's what you have been doing. Just you have to explain it in a more professional manner, better technical language, and on such stations, you will be talking to the medical experts, consultants, or a senior or a junior. So if you can use medical jargon, no penalty for doing that. Very important to know about anesthesia. What is general anesthesia, regional anesthesia, induction agents, inhalational agents, then prophylactic measures and complications. Of course, you are not supposed to know about them in detail. They will never ask you that this opioid analgesic. What is the where are the opioid receptors? You all know that they are present in the pre-aqueductal area in the brain, but they will not ask you in the exam because you have already shown them that you have good knowledge and it was tested in part 2. Now, if I will phrase it in one sentence, part 3 is all about applying your clinical knowledge, how you are imparting information for the patient, how you are using your knowledge to care for the patients. So, important aspect of exam patient safety. You should understand principles of safe surgery for operative delivery, indications, contraindications, prerequisites, when you should involve neonatologists. So, in all of such things, such activities, you need to involve the neonatologist. You should include WHO safety safe surgery checklist. You are familiar with that. We have revised that several times. Then, when you are working as an independent specialist, they are testing your abilities of that you can carry out all procedures. You have required technical and non-technical skills. Then you should be ordered to deploy your team to the best of your advantage and to enhance patient safety, patient care. Prioritization, very important. Which task needs your urgent attention? Which patient can be seen by a SHO? Where you should send your midwife, where a GP can help you, and where ST1 can help you. So all of these things are important. So how you are going to organize your work. So you should think that you are captain of a ship, and for smooth sailing, you need to deploy your staff according to their abilities, and they have the required experience, and they can carry out different tasks. So how safely you allocate cases, whom you are delegating to, how you are managing, and and you should remember that mother is in person, in flesh, she is present in front of you, so she has rights. Though fetal, we think that this is also alive, but he has not taken birth. So if you have to choose between the priorities for the mother and priorities for the fetal, you will give priority to the mother because she is your primary patient. Involve your consultant when you need. Allocate duties to everyone according to their skills. You can do everything as you do in your own labor ward and allocate them, you will be right. And these tasks, they will see that do you have leadership qualities? Very important aspect which you should observe in all stations, duty of control. Provision of healthcare, it's a risky business. So it doesn't matter that in which system of the world you are working. Even in the best of the hospitals, I have seen things going wrong. State of the art hospital, all facilities under one roof, and still something somewhere is going to be wrong. No problem, things will happen. Problem arises when we fail to identify what has happened, and then if something has gone wrong, it's an accident. We were not planning for the disasters, they have just happened, and your patient has the right to know. So you are going to tell them honestly what happened, what we have done, why it has happened, and how what are the implications of this thing for the patient right now and in her future health, and how we can minimize the impact. So after that, if patient gets angry or she blames someone, You're not going to be part of that blame game. You're just going to be honest. You are going to be firm, and you will say if you have not done any procedure, and she is asking you that doctor so and so did that one or that procedure on me, and see now I'm suffering. You're not going to comment on anyone. You're not going to criticize NHS. Okay, it will result in an automatic fail result. So don't say that. So you'll say that while I respect your comments and your opinion, but I would say that we need to dig in more into that to reach some conclusion. Can we do? I can do that. Someone is having, other your companions are being affected, so it would be better if I will just mute it. So then you will tell them, then you should know risk management and clinical governance in cases of adverse events. So we have a list of patients, a list of the clinical conditions where we need to tell them that what are the reportable incidents, serious incidents. Okay, that is one thing. So special conditions will be if your patient is unconscious, or the patient needs resuscitation, or patient needs ICU care, HDU care, especially in cases of preeclampsia, sepsis, maternal collapse. You should know that when you are going to shift such patients to the right place. So when we are talking about, these cases, you should know when you're standing outside the cubicle. Very important for you to write down that where is the patient right now? Is she is in the ER? Is she on delivery suite? Is she in the OR? Or you are having a structured discussion? Pay attention to that one. So whole demographic info they are giving you in the station, and it has a purpose. It has been inserted there on purpose because they want you to see that can you see that what complications this patient can have. If she's coming from the clinic, then she's a booked person. She has received all care. So what has gone wrong? Anytime that you see a patient who is unbooked, full stop, no one is going to penalize you for that because that patient was never in your care. So you know nothing about them. But if you had a booked patient and she meets some accident, then you can be held responsible for that. So going back to the management of delivery, this is a different module. Labor and delivery are two separate conditions with many acute conditions as well as chronic complications. Basically, your practical skill can be assessed here. As an ST5, you are expected to know about both vaginal and abdominal routes of delivery. OVD, you should know these things should be on your fingertips. Indications, contraindications, complications, CS incident reporting, patient's debriefing, and follow-up. Know about limitations of knowledge on normal and abnormal labors. Emergency CS indications, VBACs complications, elective repeat cesarean section issues, they should all be well understood. Communication and applied clinical knowledge both are very important to do these stations perfectly. Explore expectations and fears of the patients. It is a time of high emotional stress. Uncertainty is going to be there. So you have to act tactfully. Learn how to negotiate with patients. It is very important. Giving information on both pros and cons of vaginal and cesarean delivery is essential. The woman should use information you provide to make her own choice rather than be told what she should do. It's very bad. So always remember, summarize the whole info for the patient, and then ask that, what do you think? How does it feel? So this is the plan. What do you think about it? Can we execute this plan? She will say that, yeah, we can do that. So are you happy? Okay, she will say yes. Okay, then let's go ahead. Okay, so you're going to make a joint decision. Keep the senior informed. Involve the juniors. Patient's wishes, number one. Without consent, you just can't do anything. So negotiation and compromise, they are key skills being tested here. So practice against a plan rather than deciding for the patient. So agreeing a plan rather than deciding for the patient. So paternal approach is not welcome at all. You can be asked about arranging skill drills in your OB unit. You can be asked to review a SPAR. Then the domains tested on these OSCE stations are applied clinical knowledge, patient safety, communications with colleagues. And I keep revising in all sessions. Forget the domains. They are not your job. They are like different colored blocks. It is job of the examiner to sort them out. Your job is to remember the tasks. Why the tasks are important? Because if you forget something, no one is going to remind you. Remember that in 14 stations, you are going to see 4 lay examiners, 6 role players, 4 structured discussions. So you are not going to ignore anything, okay? Just remember these things so that when the lay examiner is there, then those at those stations you have the chance to score your highest, because you will be evaluated by the clinical examiner and by the lay person. Lay person is just going to see that how polite you are. Did you give patient a chance to speak? And did you address her concerns? And whenever you are seeing such patients who are indecisive or whatever, whenever you are imparting information, you have to give them something. What is that something? Patient information leaflets, internet resources, online resources, any other handouts. If you have organized some meeting, some activity for the patients, like there are many events are carried out every single day on the hospital premises, so you can give them some info on that. If you have some YouTube link, you can talk about that. Any group of people having the same problems, same issues, same concerns, you should put this patient in contact with them. Okay, so always give this information. Then in the end, you should invite questions. So these are simple tips. I don't believe in tricks. You don't have to trick anyone. Just be honest. Just do your best. And if you're going appropriately, no one is ever going to fail you. These are the points. So then when we talk about some topics, just I will just quickly go over these things because I have certain stations where you will need this information. Fetal blood sampling, and these are the international standards. That 7.2 more than 7.25. This is criteria normal result. Yeah, yeah, please. Welcome. If anyone wants to contribute, you are most welcome, dear. If the pH is between 7.21 to 7.24, then it is borderline pH, so baby is likely to develop hypoxia. If the pH is less than 7.2, it is already abnormal, so your baby is hypoxic. So after a normal result, fetal blood sampling, it should be repeated no more than 60 minutes later if the CTG remains pathological, or you will have to repeat it sooner if there are further abnormalities. After a borderline result, fetal blood sampling should be repeated no more than 30 minutes later. Anytime you see any abnormal result, you will repeat it after 30 minutes. An abnormal result should prompt urgent delivery. Urgent means from decision to delivery interval is 30 minutes. They can give you a station where you will not have the facilities to carry out fetal blood sampling. So what should be done on such cases? What will be your next action? All of you are welcome to answer these questions. Let me unmute you. So you have some concerns and you don't know how you should go forward. So what should be done now? You don't have the facilities to carry out fetal blood sampling. So what should be done now? Simply, you won't have that much time. You have to deliver that baby, right? So be dynamic. So this is just for your interest. Like green means that everything is fine, so you can do. It means that chance of hypoxia is just can occur, cannot occur. So the risk is very low. So none of the actions is required because your fetal blood sample result is normal. So in the blue category, it means that the chance of developing some problem is low. So what you can do right now is conservative technique. Begin preparation for delivery. Put the patient in respiratory position, IV fluids, and reassess the patient that she is fine or still we don't have fetal acidemia, but the things are not as good as they should have been. Be very low chance of developing any problem. Blue means that you are doubtful. Then yellow means that no centrifugal ischemia, the typical heart rate suggestive of intermittent reduction in oxygen, which may result in fetal oxygen death. So moderate risk, so you will do conservative techniques and then you will increase surveillance. So what are you going to do? Put your patient in left ventricle position and see that mom is not dehydrated. So you can start IV fluids. Whenever you are giving oxygen, it is not going to change CTG findings. It is just going to correct maternal hypoxemia. Okay? So actually, it has two benefits. You are correcting her hypoxemia, and then you are oxygenating your patient well. Because in case she will go for cesarean section and she has a low oxygen saturation, then the anesthetist will give her oxygen for like 4 or 5 minutes, and then you can anticipate this delay. So you should start giving them oxygen. So that is one thing. So and if the results of the FPS are borderline and acceptably low fetus, and the fetus is potentially on verge of decompensation, so the chances of developing hypoxia are very high. So you will do conservative techniques and prepare for urgent delivery. So in this condition, under this condition, the quickest way to deliver the baby will be operative vaginal delivery, because even for the cesarean section, you will take some time. So if the baby is already in the red zone, like we said here, that the pH, scalp pH is less than 7.20. So already hypoxia is present, so do delivery. Full stop, okay? So then these interventions we will use wherever it is appropriate. So I think that then whenever the baby's heart rate is not good, then you need to see that what are the contributory factors. Is mother hypercontracting? If that is the case, you are going to address TACI system. And if things are fine and still the CTG is not good, then you have to think about some chronic conditions which are present there and causing hypoxia. Any questions, any problems so far? It's an interactive session, so anytime you have any problem, any suggestion, I welcome your opinions. Okay, so don't worry about that. You can contribute. Just one more slide, and then we will go and we will practice with the stations. Okay, so emergency cesarean sections, and they are very important. But don't think that in the exam they cannot ask you questions on routine cesarean sections. They are going to ask you many things from there also, because that is part of everyday's OB care. So just a quick look at this one, that when you have to talk about malpresentations and malpositions, then you should know that occipito-posterior, it is present in 5 to 12% of the patients who are in labor, active labor. Breech presentation, 3 to 4% at term. I'm not giving you these because you will be confused. Transverse lie or shoulder presentation, the chance is very less, like 0.33, 0.25. Face presentation, again the incidence is very low, 0.2 to 0.3. Prop presentation, even rare, 0.07. But this 0.07 translates into 1 in 1400. So there are two important points that will help you in determining the position of the baby. Like, um, like, if you can feel this posterior fontanelle, you are feeling the occiput. Okay. If you are the posterior one, if you were to talk about the shape, this is triangular because this is logical. Three bones are meeting here, two parietals and one occipital. Anterior fontanelle, this is, this is, anterior fontanelle, this is diamond shape because four bones are meeting here. So here you can feel this coronal suture. So if we talk about the diameters, occipito mental diameter, this is 12.5 centimeter. And this suboccipitobregmatic or submentobragmatic, these are normal diameters. These are just 9.5 centimeter. Interesting to notice that face presentation, the diameter is again 9.5 centimeter. But if it is mento posterior, then the head of the baby is already hyperextended. and the baby passes through this pelvic rim through the process of extension. So if it is already extended, it cannot extend further. So occipital posterior, you are going to deliver by cesarean section. Occipital interior, still the baby has a chance that they will deliver by normal delivery. So when we talk about cesarean section, you just don't have to talk about the CS only. You have, in isolation, you have to talk about what is happening. You have to explain to the patient. As a matter of fact, in the UK practice, what you do is at 36 weeks, you finalize the plan of delivery. It's a big document. You need to ask the patient what are their preferences regarding anesthesia. Will they accept blood transfusion? Do they have any reservations? And at that time, you have to counsel them that we are looking forward to a normal, smooth delivery. But if things go wrong, then we will have to deliver by operative vaginal delivery. And for that, we can use different instruments according to your situation. Or we can deliver by cesarean section. So in both modes of delivery, you are going to talk about what type of analgesia you are going to give them, what type of anesthesia you will give, and you need to tell them that we have experts who are going to carry out these procedures. So when you're talking about cesarean section, you need to tell your patient that she will need that she needs to be reviewed by the anesthetist, what type of anesthesia she will get, what she should expect. She will take any prophylactic antibiotics. She will need this bolus catheter, and then for how long she's going to stay unconscious, when she can start eating and drinking, when she can be mobile, when we will take out this catheter, and when she can start eating, when she can go home, and how and when she should be reviewed again, and how she should expect her postpartum period to be. That how what sort of care we will provide and what complications she can have. When she should go to the A&E or to her GP. So regarding the cesarean sections, most of the patients, like 59%, they will get spinal anesthesia. 11% they will be fit for GA, and like if your patient is having severe bleeding, then you cannot give them spinal or combined spinal epidural. So you will have to go for GA, especially undiagnosed placenta previa, vasa previa, and all of these things. You will have to do GA because it is quicker in onset, so you will deliver the baby. Combined spinal and epidural, it is becoming very popular. More and more units are offering them, but still it accounts for like 7% of all anesthesias. Epidural is very popular, especially during labor. So normal labor, and it is the incidence is 23% patients are taking it, and then you should remember that taking if your patient is on epidural, then when you should suspect delay in labor, and when you will say that no, she is progressing well. So these things should be on your fingertips. Then you should know that taking this epidural, it is not going to prolong first stage of labor, but it can prolong second stage of labor, and it is one of the risk factors for having instrumental deliveries. Any questions so far? Okay, so I'm going to start alphabetically. Okay, so Dr. Amita, this is your patient, first case. So these are the domains and the tasks. So you will take 2 minutes and then we'll talk about this patient. So you all can see that how you can present this, how you can execute this plan. What is your plan? What you can do here, and then if you like to contribute, we will take your opinion also into consideration. Okay, first case is for Dr. Amita. So your time starts
Okay.
now. You will take 2 minutes.
This
Okay.
conference will now be recorded.
So this is a simulated patient task, right?
Okay. So in that case, I would first like to introduce myself, and I would like to take a brief history of the patient, like
Okay, so
whether
I'm
this
your
was a
patient. I'm your patient, so you will ask me and I will answer your questions. Yeah.
okay. First, I will introduce myself, Dr. Ramita, and I would be assisting in your delivery. And I would like to know whether this was a spontaneous conception,
Yeah, it was.
and do you have any problems in this pregnancy?
No, nothing so far. I told them during my booking that I would like to keep the things natural. I don't want any, this. I cannot take this much pain, but then I don't want any medicines also. I'm against them. Things should be natural. So I have read on internet that if I will go into bathing pool, it is much better. And but I have received this shot also because at that time I was having severe pains. So now they are not letting me go into this pool. What's wrong with that? Just one shot, and I'm fine. I have no issues. So
Okay.
why don't you let me go into the pool?
Uh, because you are in the advanced stage of labor, and uh, uh, therefore I would not recommend you going to the pool, because then uh, we have to observe you. And the second thing is the baby's head is a little high up, so we have to see, monitor your progress, because in case if you have a rupture of membrane, or there would be high risk of, you are at a high risk of cord coming out before the baby's head. So that would has to be taken care. If you are inside the pool, then those kind of things and monitoring would not be able to be done. I
But
would like to know certain, yeah, what are you
they
saying?
told me before that the head was down. So what are you telling me? What do you mean by this high head? You people told me that things were fine. So why you are telling me now that the head is high?
Things are fine, but we have to keep monitoring you, that with time you will be progressing. So we will be monitoring you, how your progress is. With as you are having contractions, your head will come down further. So when your head will come down further, it would, we are supposed to assess how it is progressing. So with contractions, your head may come still further down.
So okay, I get it. Got you. So but what is the problem? Why don't you let me go into the pool? The baby is fine, and I can feel him moving. So what is your concern? What will happen if I will go to the pool?
The concern is that in case if you have a rupture of membranes,
Mm-hmm.
there may be incidence of cord prolapse, so at this stage we do not want you to go into the pool, because you are in advanced stage of labor, you are is in active labor. So you could have gone there in case of an early labor, but now since you are in the active phase of labor, in active phase of labor we do not permit you to go in the pool.
So what do you mean by this card prolapse? What is that thing?
Means because your head is little high, there are chances that babies, the cord connecting the mother and the afterbirth may come out before the head. So we have to keep observing you. You are in advanced labor, so we cannot send you to the pool, because we have to monitor your progress, and inside the pool we will not be able to monitor your progress, since you are in the active phase of your labor.
Okay.
Now,
So,
would you
so
like to tell me? Yes, yes, tell me.
yeah, I want to go into the pool because I will feel less pain. And then when you think that the baby is ready to pop out, then you can take me out. No big deal. So I just don't understand that why you people are behaving this way.
Okay, I'll explain it to you. But would you like to tell me, was this your first is this your first pregnancy?
Yeah, that's my first pregnancy. Yes.
And there had been no miscarriages and nothing. This is your first pregnancy.
Yeah. Yeah, nothing.
Okay, okay. And earlier cycles were all regular?
Yeah, things were fine. I'm 27. I'm healthy. I don't have any issues. Only this
Do you
pain
have
is.
any,
Yeah.
yes, do you have any drug allergies?
No.
Okay. And uh, do you have any major surgeries or any medical problems at present for which you are taking any medicines?
No, nothing. Just I had this, tonsillectomy They removed my tonsils when I was like, I think 7 or 8.
Okay. And you're not smoking, or are you smoking? Do you have alcohol, or you are into any illicit drug use?
No, nothing, nothing. I'm clean because I'm pregnant, so I'm not exposing my kid to any harms.
Okay. And you do not have any family history of thromboembolism, or parents are otherwise healthy?
Yeah, yeah, they're fine. Just my mom is obese and she has pre-diabetes, but my father is healthy.
Okay. So, since you are in active labor, so we would recommend you, because there's sometimes you stay, we can offer you other things for pain relief. And uh, if you want, many women can cope up with pain. In case if you are
Mhm.
having pain, we can offer you epidural, we can offer you other forms of analgesia. And in case if you want it natural, so you can bear these pains. Are you able to bear the pains, or is it too hard for you?
Okay, so what is the final decision? So you will let me go into pool or not?
No, I will not recommend you to go to the pool. Uh, and you will be reassessed after 4 hours, and we will be monitoring your pulse, your temperature, your urine output, and your vital signs. So, monitoring will be better in the labor rooms.
Okay, so 9 minutes. You still have 2 minutes. You like to revisit your station and come up with something?
And we will be monitoring your, we will be using a partogram to monitor your labor. And
Hmm.
that's all. Uh, and in case of pain, if you want, and pethidine, I would not recommend pethidine for painkiller, because mm, uh, uh, in pain, I would like you to use some natural methods. As you said, massage can be offered, or uh, if you want to listen to music of your choice, or you want to have some deep breathing, or whatever you want to have. But pethidine, I would not recommend you.
Okay, so you like to stop here?
Yes.
Okay, so let's go over it. So no offense, nothing. So how will you rate your performance?
Uh, Actually, I did not know about this. I only know if the temperature of the mother is, if she's febrile, she cannot go into the water pool. But I am not very sure. I have never experienced this labor in under pool or in water. So, what my assumption is, कि when you are in active phase, it would be difficult. Matlab, you can be in the latent phase in the pool, but in active phase, I'm not sure if you permit patients to the water pool, or I do not know. So that what I said according to my general conventions. I The only thing about pool was that I know ki if the patient is febrile, she's not supposed to go to the pool. And pethidine, there is increased incidence of convulsions, and so pethidine say better. There are other choices like morphine, but then that can cause baby sedation, and even pethidine can cause little sedation, so that is not a preferable method of choice according to me.
Okay. So in which stage of the labor she is?
She is in the active phase of labor.
She's in the active phase, right? And she has
She is
taken.
in the first stage of labor, first
Yeah,
stage, and that too in the active stage.
yes, that's how she is. And where is the presenting part?
Presenting part is at -2 station, which is well above the 0 station. So
So yeah,
uh,
go on.
so in case if she has, the head is not fixed, so
Okay.
-2 is little high up, so she may have a failure to descend, and she may have uh, meconium, she may have cord prolapse. So these are the things which have to be taken care.
Okay. So as such, she is a primary, she is full term. So as such, she is not at a high risk of developing anything. But the point is that this girl, she's 27, things are fine, but head is still high. Where do you expect in the primary that head would have engaged by 36 week of pregnancy? Isn't it so? Right? So that is
Yes.
one risk factor. Second, she is asking for two things: birthing pool, and then she wants pethidine also for pain relief. The first shot they gave her, we don't know that that was Buscopan or something else. So that is, these are my observations. Then going back to your performance, you didn't ask her name, right? Cook case, regular care, everything's have been fine in this pregnancy so far. I understand that OSCE, during OSCE, you people are performing under tremendous pressure. And then you have social pressure also that you need to do very well, right? All of these things. But my advice would be that develop this practice. Don't panic at all. Just do anything that you will do for your patient. So this patient we have got several. So first intro was missing, and how she has been doing, and things are fine, but the head is a bit high. So you should say that. Like you should take a history, and if you came back to the history and you addressed all of those points, but you should have taken that history before, okay, before telling her anything. Sometimes you will get patients who would have
Now,
like,
I want to interrupt here. Like, if the
yeah,
patient is asking once, twice, thrice, so uh, that is a confusion whether we should tell the patient or first go and complete the history. Because if you
yeah.
asking twice and if I don't answer you, won't that be taken as a harsh behavior?
Yes, you will say politely that I understand your concerns and I will answer that in a while. So, yeah, it is safe. You can think about it. But let me take, if you allow me, I can ask you a few questions. She will say yes. Okay. So just give her a small affirming note, a small sentence, and then go on to that one. So you have taken history. So what are the risks for the fetus? You will say that head is a bit higher than we expect, and then in the second stage of you are in the second stage of labor, and we need to monitor the baby. So for that we need to do auscultation. So every time we used to check the heartbeat of the baby, that how baby is coping with the stress of labor, we will have to ask you to come out of the pool and do it, and then it can be quite inconvenient for you. Then regarding the temperature, we need to check it very frequently. Then we need to assess you also. And then if you will take this injection, let me tell you that it can make you a bit sleepy. You can have vomiting, you can have nausea, and you may sleep in the pool also. So though one person will be present with you, but it would be like a bit inconvenient for you to come out when you are drowsy and you need to come out every now and then. That's not an ideal condition. And then regarding your condition right now, we are not sure that which way you will move. So we are going with still now the things are fine. We anticipate that with contractions, this baby will come down and we will be able to have a normal delivery. But on the other hand, if baby develops some abnormality and we are not monitoring properly, then we cannot decide when to stop and go for the other options like that. And that's all you need to tell her, and you should tell her about the alternative methods of pain relief. That pethidine can be used, but we have better drugs than pethidine. We can give you diacetyl morphine, which is diacetyl pethidine, which is morphine, which is more potent analgesic and associated with less side effects. So we can do that, and I would suggest that we need more frequent assessments. So you should try. You should be kept outside this pool. Okay. So if you really want to go into the pool, that is your decision, and we respect that. But I have told you about the differences that you may fall asleep, you may slip when we are asking you to come out, and it will be very inconvenient for you when on one hand you are having pains, and then it can delay the process of identification of this fetal distress that baby is going through any problems. So it can affect your care. So I have given you all the facts, and if you still insist, if you will say that no, I want it, then we'll say okay, let me document it, and we can proceed with it. And but we need to make this whole process very safe, and the midwife is going to stay with you. That's all. And remember that all stations, they will not take equal time. Some of the stations, they will end within uh, even 6 minutes. Okay? So don't be upset on such stations, because here this patient is just asking you about this thing. Okay, so just give her all the information about this pethidine and the breathing tool, that they are associated with decreasing the pain. And but the problem is that monitoring of the baby will become very difficult, and we are not 100% sure that you will be having a normal delivery, because the head is a bit high, many things can go wrong, and we need more frequent assessment after giving you this pethidine. So it would be my suggestion would be that you should stay outside this birthing. Do you have any question? I will give you more information. I've given you information, so take your some time to decide, and then we can proceed. So tell her about the alternative methods of pain management. You can give her morphine. You can give her epidural. It can be cyclic because she is still in, but you will tell her that we need to give repeated doses, and then we need to test you, and then we will have to check the fetal heart rate additionally. That's what you need to do. And you will say that I will document everything in your notes, and if you have any other question, you can ask me about that. You can get a similar scenario where your patient would have, she would have undergone previous two cesarean sections, and now she will be insisting that I want this baby to deliver normally. So she would say that I have read on Google that it is safe. It is not going to increase my risk. So what happened? One aspect was patient safety. Sometimes the candidates, they will continue talking about the safety, safety, and safety. Safety is very important, but there is more to it. So what happened? By this fellow said that if you will not agree, I will call my consultant. Then the woman said, call anyone. I don't care at all. I will not undergo this cesarean and other time. So they both continued to argue, and 10 minutes were passed. So he got full marks in patient safety, but failed the station overall because didn't address other issues. So here you have got 4 tasks. Okay. So when they divide the task in four, it means that you are going to talk about each of these tasks for like 1.5 minutes. 1.5 minutes for you, 2 minutes for the patient because she will be saying something, so you will take into consideration, and then the last 2 minutes for you to summarize the whole information. Okay, that is the point. So the best way is to record yourself and see that you can perform everything within 6-7 minutes. That is the standard. Okay, thank you very much. So any other concern, any suggestion, any point?
That's all.
Okay, that's great. Thank you very much. I know it was a difficult station. Things they seem very simple, but home birth, water birth, all of these things in adamant patient. Sometimes the patients they will say that no, we want to deliver at home. Come what may, I will not go to the hospital. In that case, you will do your best. You will document everything, and then you will inform the the each unit. It will be under the care of some consultant, some obstetric unit of some hospital, and then you can refer the patient for second opinion. Okay, these things are important. And all of this information has been taken from NICE guideline on intrapartum care. Thank you, dear. Dr. Wasavi, are you there? Hello.
Yes, doc. Yes, doctor.
Okay. So this is your station. You will take 2 minutes and then talk about it. Pay attention to the tasks because you need to spend like 2.5 minutes addressing all of these issues. Okay? So your time
Okay.
starts now.
This conference will now be recorded.
Okay, can we start? Dr.
Hello.
Wasavi. Right.
Yes. Hello, my name is Dr. Vasavi, one of the doctors on the labor ward. Can I confirm your name and age?
Yeah, I'm 30 and my name is K.
Nice to meet you.
Thank you.
And I understand you're referred from the low risk birth unit. And so, how you're getting the pains now?
Pains are fine, but I was they have been telling me right from the start of pregnancy that I had no rest. So I have phobia. I can't stay in the hospitals. And then at this time, they have just shifted me to the hospital. I simply don't get it. Why it has happened.
Uh, Okay, Ms. K, I will explain to you. Now we have some concerns about the baby, and um, f- from the notes that baby has passed poo inside, and also when we are monitoring the baby's heart rate has concerns. So uh, it's showing baby's heart rate is showing some what we call as dips with the pain. So we're concerned about the baby's heart rate. What I will do is I will ask you some questions regarding this pregnancy, and I will explain to you what we're going to do further. Is that okay?
Yeah, that's fine. Yeah, but
So
you
yes,
have been telling me
any
that I have no problems, I had no issues, and now suddenly you are telling me that all of these problems have shown in my case only.
um, so for now, baby has it means when the baby has passed poo inside and the baby's heart rate is slowing with the pain, that means baby that is shows baby might be in distress. So for now it could be because of the baby cord around the neck or some other reason. But we have to do the further testing to know whether how much distress is baby is in, whether we need to expedite the delivery.
Okay.
So during is it a booked is it a booked pregnancy, antenatal visits?
Yeah, seems fine. Yeah. Yeah.
Do you have any problems during this clinic visits? Any problems
No,
in the antenatal period?
no, no, never. It's a planned pregnancy. This is my first baby. I never faced any problems. So things have been fine so far. Only now I'm stuck here and I'm under tremendous pressure why it is happening. What has happened?
Uh, all right. So what we do is we will make you turn because most likely the baby is not getting the enough oxygen. Either it could be baby might not be getting enough blood supply, or maybe the cord around the baby's neck. What we would do is we will put you in the left lateral position, and we will start the drips. And what we do is I will assess you to see how dilated you are presently, and where the baby's head is. And I will do a test called fetal blood sampling. What it means is I will pass a small instrument, and um, and just a scrape on the baby's head to get some blood sample and send it for testing to see how much how much like oxygen concentration in the baby's blood is, so that we would know whether we have to deliver the baby immediately or we could wait for some time, allowing for the normal delivery. Is that okay for you?
Yeah, I can understand. So what about my
Um,
delivery? Am I proceeding for normal delivery or again you are going to give me some bad news here? I'm already stressed
um,
out.
um, uh, yes, your concerns are very valid. For now, it's good that that having a natural labor is good thing, and so that you could avoid the complications for the operation. But in case baby is having low oxygen saturations, that means we might have to expedite the delivery, either by assisting you with uh, um, if you're fully dilated, we will assist you with the forceps, a pair of instruments, or if you are not fully dilated, then we have to do the cesarean section depending on the chest disease.
So finally, what will happen to me?
Um,
Well,
for now, we'll be doing the test now, right?
okay.
And so, what are your concerns about cesarean section?
I never had a surgery. I'm so much scared. What will happen to me? What will happen to the baby? And can't we do without having this cesarean thing? It was not on my radar, you know.
Um, so, with a normal delivery. I will explain the options of both allowing for the normal delivery and options for the cesarean section. Right? If we allow for the normal delivery, it could progress. It could progress well, and we will be continuously monitoring with the baby's heart rate, and we would be monitoring with the with the doing that blood sampling. But in some cases, if the distress is more, baby might have come up with sometimes having um, floppy with sometimes having brain injury is one of the complications in the long term. And there is a small risk of baby dying.
Are you telling me this baby is going to die? Oh my God, why? This must be your fault. Things you have been telling me that things are fine, and now you're telling me that I'm going to lose this baby. Can't take it. This is beyond my comprehension.
Um, we don't know exactly why you are having this, because the labor is a process. Sometimes unexpected things happen. So one of the things, it could be if the if the baby is not getting the enough blood supply, we have to expedite the delivery so that the baby will the brain will not get damaged in the long run.
Okay.
And uh, uh, as of um, uh, and if you're fully dilated, we could help with the delivery using a pair of instruments. Is that okay for you?
Yes, I want to have a safe delivery, so but I need to think about it. Like that, then I can
Okay.
decide.
Yeah.
Okay,
And the
so you want,
option
yeah, go on,
and
please.
the other option is the cesarean section.
Mm-hmm.
Um, yeah, and I will ask the anesthetist to speak with you about the type of anesthesia, and we'll be giving a lower incision and delivering the baby. So usually you would be in the hospital for 2 days, um, and most of the cases will not have any complications. Um, and there is a small risk of infection, bleeding, and anesthesia complications.
So what about the baby? You told me that baby is going in the water. So what will happen to the baby?
And so baby will be immediately taken care of the pediatricians. I'll call the pediatricians. As soon as the baby is delivered, baby will be assessed by the pediatricians, and there will be sometimes if the baby is having any problems, baby might need baby will be assessed immediately by the pediatricians, and they will inform
Let's
you.
stop here. We have taken one additional discussion. So time constraints. I'm not being rude. Time constraints are very important, okay? Because once they will ring the bell, you will have to go to the next station. So let's analyze your performance. Nothing personal. I want you to score maximum during your exam and pass your exam, inshallah. So it was a simple station, right? And things could have gone in either direction. So there is some fetal distress. You were justified in saying that baby is having some problems, maybe less oxygen is going to the baby. So, and you asked about the antepartum, antenatal history also, which is good. And you asked about the labor also. Was it initiated or she is in spontaneous labor? All of these things have been normal or not. Okay. So when they ask you that what is your initial assessment, assessment always means you're confirming the history. Just confirm whatever they have told you in the history. You will just confirm it from the patient. You should not spend like more than 40 seconds on that. Initial assessment means that what is she getting? Is she this IV line here is here because with this bad CTG you will have to insert IV line, and then as I said that any patient, if she's shifted from midwife-led unit or from the home birth setting, you will treat her as a high risk patient because something somewhere has gone wrong. That's why that patient has been brought to the obstetric unit. So my reference is NICE guideline on intrapartum care. So that guideline is very important because you need to address all of the aspects of the care. And those two guidelines, they are very lengthy. They can take you somewhere between 5 to 6 hours, but they are really very helpful during exam because in this condition you have in this station you have just a low risk primary, right? They said that she was termed she was in a low risk birthing unit, so things were fine. So that is the stuff. Yeah, yeah, dear. I like to mute all. So if you have to comment on something, you are welcome to talk about it. Okay, so you can unmute yourself. We have this provision. Okay, dears. So someone who has been shifted from home or an asylum seeker or those people who are already living a marginal life. Unfortunately, those people which are homeless, they are on drugs, or they are in the, this, and they are working as prostitutes, like sex workers, then those who have some underlying medical disorders. These four groups, and then minors, teenagers, they are in the high risk group. Then teenagers and mothers who are in their 40s. Primaries and those here who are in their 40s, they are going to have more problems during labor because their uterine muscle is not going to work in a better, effective way. So they are bound to have complications. We'll talk about them also. So with this CTG, when she has been shifted to the obstetric unit, you need to carry out full assessment. I will not go into the details. You know that you need to take the vitals. You need to start continuous fetal monitoring, start IV line, inform the senior, send blood for group and safe. Don't bleed anyone. So you will not say cross match only when you're pushing the patient to OR. Because with this CTG, you can see that. You didn't analyze with the CTG. Okay, can you comment on that one? DRC bravado, we will say. So, but you told her that the CTG is not very good. So baby is having some problem. Maybe the oxygen is less. So then always ask what has been done so far because you are going to build your further assessment plan on the basis of initial plan. What has been done so far? Is she receiving oxygen? Has she been put in left lateral position? Has someone informed the senior? You should be informing them. Okay, so yeah, that is the thing. Continuous fetal electronic monitoring. With this CTG, FPS is recommended. So at this, whenever you are doing any intervention, always check: do we have any contraindications to this condition? Do we have any contraindications for FPS? Is mother carrying some viral infections? Sepsis is there. Is there any history of bleeding disorder? Just exclude them. No, these things are mathematical. They will give you edge over the others, okay? Exclude all conditions, no infection, no bleeding disorders. Mother is consenting for it, she will show her concerns. So what are you going to do? Are you going to cut the head of my baby? You will say, no, we are simply going to scratch the head and then we will put this small device. You will just take the blood sample and we will analyze it. Why you will do that? Anytime you are doing any intervention, why you are doing, what benefit you will get from it, and what will be your next action. These three things, these all three should come automatically to your mind. Okay? So tell her about that, that if it is in the normal range, we will continue with the trial of normal labor. But if there are some concerns, then unfortunately we will have to rethink our plan. So then we will, since you are far from labor, and if the baby is developing some problems, when you will reach this point, they may give you a strip that this is the result of the PS. So okay, in the light of that one, that you will have to decide that you need to deliver that baby, or you can still give her a chance to progress, because 6 centimeters is far and away from the this labor, that she will be near this delivery. What is your plan for her delivery? She can go both ways. So you have to tell her about continuation, that if things are fine and she is stable, no maternal or fetal concern, you will continue with the normal delivery. So you will give her a chance. And then besides that, you must have noticed that this CTG, for how long they have been carrying out this one. So whenever you have a CTG, always check that patient's biodata is there. Sometimes, especially in the structured discussion, they can give you a CTG of another person. So you will like to confirm the name of the patient, demography, time, date, when we did. So what is the paper speed? Paper speed matters a lot. In most of the units, they will use for the paper with 1 centimeter per minute. That will be the speed. So for how long she has been having it. So actually, can you still give her a chance? So if there are variable decelerations, is there any shouldering? Here I can see, but here I can't see any shouldering. So no shouldering means that a bad chance. So still you can continue with the CTG while you are trying to resuscitate her. Then tell her about the cesarean section. She will say that cesarean section, what is the problem? So why you, and she can ask you that why can't you take it out with some spoons? So you need to tell her that she is far from labor. She's just 6 centimeters. So in that case, if we need to expedite delivery, most likely we will carry out a cesarean section. So she will ask you that why do you want to do that? You will say that we are going to do a cesarean section, like because we have concerns about the baby, so we need to carry that out. So what can happen then, whenever you are talking about the cesarean section, make it a habit. Tell her what she will take now. Before procedure, she will need antibiotics, she will need anesthesia, should be reviewed by the anesthetist. And whenever you are taking, if there are serious concerns, then like the CTG is showing a deep T cell lasting for 3 minutes, you can push the patient without consent. My reference is clinical governance guideline. It is on the RCG website. And consent can be required, can be fulfilled later. It can be written later. So you will take that one if you're going for Cat 1 section, which will be an emergency section because there is immediate threat to the life of woman or fetus. Can be either ways. Then what she should expect interpartum. Anesthesia will be given. Cesarean will be done by someone senior. The problems you can have during cesarean section, like there can be injury to the viscera, or you can bleed a lot, or there can be extension of the scar because the head is deep at this point. So, and you are in active labor, so you can bleed more, so you may need blood transfusion. So whenever you are talking about the complications, talk about the maternal complications, about the fetal complications. So you need to show that you are actively applying your clinical knowledge to the scenario. Interpartum, these things have happened. So she can have postpartum hemorrhage, then she will be kept in the HDU in the recovery for a while till she is stable. We will need, and the baby immediately after birth, baby will be seen by the neonatologist. We will take blood samples from the card to see that baby was hypoxic or what, and that is important for the further care of the baby and also for your litigation. You should say that. It will guide us to the next step in the management of the baby. That is one thing. She will have to stay on the recovery room. Then she will be going back to her room, and maybe she will need an additional dose of antibiotics if she has some risk factors like she's obese. This is just a simple scenario, but if they give you someone who is like obese or something, then you will have to reassess her risk factors and her chances of getting some additional antibiotics, or uh, for the appropriate postpartum prophylaxis. Emergency cesarean section, you are going to give them VTE prophylaxis. Please don't forget that point because that is number one direct cause of maternal deaths. If you will not say that, then you are compromising patient safety. So do all of this, then she can go home and the rest of the management will be according to her condition. And you will say that right now it will increase this cesarean. If you have to go for cesarean section, it will increase your for some problems for you in for our like you will have to stay in the hospital for longer. You will need some shots, and then this intervention has some implications for your future pregnancy also. So you will have to mention the chance that in next time you have 1 in 4 chance of having a repeat cesarean section. So that's all you need to tell her. Even in instrumental delivery, that is not an option. So don't talk about that. Okay. If things are fine, we will give you a chance for normal delivery. If things are not fine, then we will have to deliver by cesarean section. Do you have any questions? Okay, invite questions and then okay, I will document this information in your notes. That's all you need to tell her. Any questions, any problems? Okay. Dr. Amita. Thank you, Dr. Vasavi. Dr. Amita, are you there? Hello.
I'm there. I'm there.
Okay, welcome. So next station is for you. You will take
Yes.
2 minutes and then we'll talk about it.
This
Yes.
conference will
Uh,
now be recorded.
Hello, I'm Dr. Ramita. I'm taking care of your ANC clinic. Uh, may I know your name?
Yeah, yeah, my name is Kim.
How are you
I'm fine.
now? Would you like to tell me something about your pregnancy? Is this your first pregnancy?
Yeah, this is my first pregnancy, and it is something like I have always been dreaming of. We have been trying to conceive for the last 10 years, and now we are overjoyed. We are over the moon that finally we are going to have a baby. It's an awesome feeling.
That is very good. Uh, you've never had any miscarriages, and this is your first IVF pregnancy. Am I correct?
Yeah, yeah, this is a test tube baby, but that's fine because we tried before, but nothing happened. So now, luckily, we have
And was it
taken.
conceived in the first IVF cycle itself?
Actually, this is my second IVF cycle. Last one failed.
Okay, okay. And are you are coming regularly at ANC checkups? You're coming regularly for ANC checkups?
Yeah, it's a very precious pregnancy for us. So I have been regularly following up in the same hospital where they did this test tube baby for us.
That is very good. Do you have any medical? Are you taking any medicines for any other medical disorders? Do you have any medical conditions coexisting?
Only my BP was a bit high, so they gave me some low dose tabs. I think the name is labetalol, but just a tiny pill. I'm taking one, in the morning and in the evening beside, but the things are under control. Nothing happened. I didn't suffer
Okay.
any side effects also.
And did they tell you something about your urine in your urine samples? Are they normal, or they have mentioned some high risk factors in your urine samples also?
That has always been fine. They didn't tell me anything. They didn't tell me that I was having any infection or any other issues. They told me that things were fine. But the only problem is that, it's a very important opinion for me. So I don't want to give birth among strangers. I want to deliver this baby with my family and friends. It is a life-changing event for me, and I'm not going to deliver in any hospital, in isolation, as if I'm in a prison.
I do understand you. What about your family? Is there any family history of thromboembolism, diabetes, or hypertension, or any other medical disorders in the family?
What is this thromboembolism? I don't get you.
Okay, this is when somebody in your family has a history of getting clots of blood anywhere in the body. Is there somebody in your family who's suffering from blood
No,
coagulation
no,
or some
nothing that I
clots in the body?
no, nothing that I
Okay.
know of. But it must be very
Uh,
horrible.
yes, it is very horrible, and that is why I was asking you. Uh, do you smoke or do you have alcohol or on an illicit drugs?
I don't smoke. I used to drink only during parties, but in my pregnancy, I've never taken even a single shot of alcohol. I'm clean. I'm abstaining.
Uh, I would like to tell you certain things. First, you want to have a home birth. Are you? Is that true?
Yeah, that's true.
But I would recommend that you should have a hospital birth, that too in a consultant-led unit, because of certain high-risk factors which I see in your case. The first is your age. You are little. Uh, your age is more than 40, which puts you into high risk category. Secondly, it's an IVF pregnancy, very precious pregnancy, and we might waste some time in transfer in case if something wrong happens and transfer happens from your home to the hospital, we might lose the baby, and that would be very unfortunate. So we don't want the loss of time in transfer in case of some mishap happens. So it would be
Okay.
better that you deliver in a consultant led unit.
Okay. But
And plus you are having your blood pressure which is on the higher side and you're taking medicines for it, so I would recommend that you should be admitted to the hospital and we induce you for normal labor. We will be monitoring you continuously through a machine called CTG, because since you are a high risk case and your blood pressure is also uh, increased, by this time you should deliver, because there is a high risk of stillbirth with anybody, and with blood pressure this high and you're having medications, I would recommend that you should be induced for normal labor. That can only be
mhm.
possible in a consultant led unit.
Okay.
And
So you're telling me that I should deliver only in the hospital.
that too in a
And
consultant led unit,
okay.
so that
So
we can monitor your labor continuously, and we will have a pediatrician present who can take care of the baby as soon as the baby is born.
okay, so I should, so you're telling me that I should go home, and once I start experiencing pains, then I should return to hospital, isn't it so?
No, I want you to discuss it with your family members, your partners, that you should be admitted to the hospital, and we will induce you so that you may have pains. You should not wait further for pains. By this time, we should admit you to the hospital. We will try to induce you so that you have pains, and then if pains are coming, we will monitor you continuously, and if required we can also increase your pains also.
I need to think about it.
Yeah, you should think about it and you should let me know. Since you are a high risk case, I will also inform your case to my consultant. And uh, uh, would you like any other questions or any other things you would like to know from me?
Yeah, one thing is bugging me, that how often do you shift patients like me from home to the hospital? I mean, how common it is?
It depends upon the other risk factors, like if it is a very low risk case, like supposingly you had a natural conception, you were uh, less than 35 years of age, and you had no hypertension, so in majority of the cases people do deliver and we do recommend home births. But in your case, since the number of risk factors, so I would not like you to go for a home birth, because then there would be a high risk of interventions in your case. So those interventions are not possible at home.
Okay, I need to think about it.
Yeah, take your time, and once you have decided, you can come to the hospital. And in case of any other query also, I will be giving you the number, which will be a 24-hour helpline, so you can contact anytime whenever you feel like.
Okay, okay, thank you. So want to stop
Thank
here?
you. Yes.
Okay, well done. You have covered most of the points, but you never asked me that why I want to deliver at home, right? That info was
You
missing.
told me na, you told me that you don't want to go to strange
Yeah,
places, you don't want to
yeah. I tricked
in
you,
the.
right? So she, if you will ask her patients, they will make up stories also for you. But as an obstetrician, it's your job to ask them again. Okay, okay. So okay, that is one of the reasons. Any other concerns? Okay, you have to be inquisitive. Maybe she will tell you that her friend, her sister, somebody delivered at home and they were fine. So then in that case, you will tell her that everyone has different risks and different advantages also. So tell me about your sister, how old she was. She will say that she's 35. So you will ask her, was it her first delivery at home? She would say, no, no. The first one was delivered in the hospital, and the second and third he had delivered at home. So then you should say, you see, even she had first delivery in the hospital. Okay, so home birth, it's a very romantic idea, pretty safe. Everywhere in all healthcare systems, they are trying to increase the uptake of this home birth. But the problem is that with all efforts, still just 3 to 4% people they want women they want like to deliver at home. So if they give you in the exam, as certain cases we'll talk about them, but first let's dissect this case. So your challenge in the OSCE is to talk about the the single patient which is in front of you, okay, or her history has been displayed in front of you. So that's why we will not generalize things because we are not giving a lecture to part two people. Okay, we are just talking about this case categorically. You will be tempted to say many things like you don't have so any this many patients they will deliver with me in the hospital. This one will go there. Just one case and you. Others they are just silent observers. Okay, like consider like you are in the some Roman theater, okay? Only you and the lion is there, and the others are just spectators. Of course, it is not that horrible, okay? Others are just watching you, silent spectators. Never be scared of them, okay? Just focus. These 2 minutes, when you are standing outside the station, they are going to save you. What are the risk factors? 42. Non-traditional person in labor. She is at 41 weeks of gestation. What is the RCG recommendation in the SIP? That the risk of unexplained
You
stillbirth
know,
is very high, 39 weeks, right?
1%.
Yeah, one
Yeah,
person.
after
But
39 weeks,
still,
it is 1%.
yeah, let me clarify one thing. This 1% above the background risk. Okay,
Okay.
that is the point. So if you will go to the AFFIRM study, it was published in 2018. It said that chance of risk of incidence of IUFDs has increased, but still it has not made its way into the RCG guidelines. But rather, this Embrace report is telling you that the number of these neonatal deaths it has decreased, but for the stillbirths the number is the same. Actually, the number of the stillbirths has increased, but still they change their guidelines. We cannot comment on that. Okay, so you should tell her that risk of having death of the baby without any causes 1 in 200 in such pregnancies. So there is enough medical evidence that we should deliver in patients in your condition by 39 weeks. So you are already a bit overdue. So you were justified in asking her about the medical condition, but you didn't ask her that what the scans run on the baby and what was the result, because at in 40 plus the risk of aneuploidies will be higher. Okay. IUGR, baby is okay. Did they tell you that they have any concern regarding the size of the baby, health of the baby, something, everything like that? Do you feel fetal movements? Okay, that's fine. Then you should tell her that your BP is already a bit higher, so we need to keep you inside hospital, okay? And when you will ask her what she's scared of, maybe she will tell you that episiotomy, or maybe she will say that you will do the cesarean on me, or you will put a painkiller in my bag. So you will say that all of these interventions are done when they are thought to be helpful for you. They are considered beneficial for you. So don't be scared. And we will never do anything without taking your permission. So this is high time you should have delivered. So we are going to admit you, and you need to make up your mind about it, because she's at 41 weeks. You cannot give her 1 week. Okay, so just give her a brief time that you can discuss, and then we can proceed further. I like to start this in the labor artificially. Then we will talk about the methods. Okay, so she will ask, what will you do? Are you going to put some tabs or something? Then you need to tell her that we are going to start the labor artificially. Before making any plan, I need to admit you, and then I will do this full examination on you. I will see that how the baby is doing and how you are doing, because you have to do the fetal assessment before starting induction of labor, and then you have to do abdominal examination. Never forget that. All candidates I've ever come across, they will do the only the VE, and then they will make up their plan. Abdominal examination is important. Maybe the head is not even engaged. 5 by 5 palpable. What is the presentation of the baby? Size of the baby? Things are fine. Is she suitable for induction of labor? Which in this case she should be, but because as such there are not many contraindications to induction of labor. Like if she has a repeater and she had this VBAC, even then you can induce her, but you need to tell her about that. Tell her about sweeping and stretching. Then if we need, we will cross match. We will keep her inside hospital. More monitoring. We will give you some taps from down below, and they will start the labor. Then, in view of her high chance of having encountering some fetal complications, we need to do continuous fetal electronic monitoring. We need to do that, which cannot be done in the home, or which cannot be done even in the midwife-led units, both in standalone and standalone. We cannot offer that. So even for if you have to site CTG, you need to shift them to the hospital. And tell her that if someone is giving birth for the very first time at home, and they are in the younger age group, still 4 out of 10 patients, they have to be transferred to the hospital. And if it is a case-based discussion, they ask you that why do you need to shift them? So most common cause is your patient will request epidural. And then second cause is that the chance of fetal distress is high. So due to fetal complications, like 7 to 9% patients, they can go to the obstetric unit, especially more so in the chance of having this is less in the primaries, but in the multis, you can have this problem. So during her labor and delivery, all of these things, we just kept talking about this risk and the benefits, but how you will arrange her labor. Induction of labor, delivery in the obstetric unit, you will inform the neonatologist, you will group and save. IV line will be cited, because all low risk patients, they don't get this IV line, but she's a high risk patient, so we will cite IV once she will be in established labor. Group and save, inform neonatologist, continuous monitoring, one-to-one care, and just mention all points that what observations of the mother are required. Continuous fetal electronic monitoring. If any change, we will keep a low threshold for surveillance section, and we will do that. Okay, then you will say that I will document all information. Do you have any questions? Then will you like to share with me? And then I will write down everything. So we are planning this induction of labor, and if you will agree, we'll just start it. We will do all investigations. We will start. And when you are talking about the complications, you should tell her that induction of labor, if we are starting labor artificially, it is not always successful. 30 to 40 patients, they will not progress. So in that case, we will have to do the cesarean. So it will have some implications for now, like it will increase your morbidity. Baby will be fine, and the baby will be reviewed by the neonatologist, and it has problem for the next pregnancy also. So I will document everything. Do you have any concerns, any questions? I'll be happy to answer those. So all of these things you will say. So home birth can be a structured discussion also. So you need to ask that they will ask you that what do you think, why do people like to have home births? You will say that they want to deliver in a familiar environment. Then they have other concerns also, like if they are healthy and they have low risk pregnancies, then there are no concerns, they can deliver at home. So what are the benefits of having home delivery? Less chance of having episiotomy, less chance of having cesarean section because we are not doing excessive monitoring, so less chance of going for the surgical interventions. She will be she will not need this epidural, and then she will be happy because she will have this social support, family support will be there, and then she will be free to move around. She can change her positions, she can take a shower, she can eat or drink, and you will tell her that she can take light meals in the early hours of the labor, and she will be enjoying the comfort of her home, and she will be in the familiar surroundings. These are simple points, but these matter a lot to the people who want to deliver at home. Then home, you should tell her if they ask you that in which conditions you will outrightly refuse the patient this chance of having home birth. You will say if they have medical disorders of pregnancy. Then Amita, you again use this medical jargon. Okay, medical disorders. Do you have any health issues? You should say that. And thromboembolism, any history of forming blood clots on the leg veins. Okay. So you corrected yourself after, but these things should be now in your mind. Okay. So if the patient is
Okay.
diabetic, there is something wrong with the blood pressure, or you can say if you are having toxemia of pregnancy. You don't have to say that preeclampsia. You will say if you have toxemia of pregnancy, they understand it. Or if you are delivering before time, like that is the preterm labor, or you have history of delivering very quickly in your previous pregnancies, or you break your water, or you have high risk of developing some infections, then we should not be giving you, we should not allow you to deliver at home. Then you should know that when they are going in the NHS, whenever they are going home for the home birth, you will tell your patients that they will not be cared by just one person. Okay, when their time of their duty is over, then there will be a safe handover, and next person is going to care for her. One person is not going to stay with her for the whole duration of labor. Then usually, when these midwives are going, they will have IV fluids. They can carry this portable oxygen also, and they will have these handheld devices like sonic aid and stethoscopes will be there, and they will have medicines to slow down or treat this hemorrhage also. Misoprostol will be with them, and oxytocin is also there, but they will use intramuscular route. That is the thing. Okay. So sometimes they will tell you that if the patient wants to use some herbal medicines during labor, you will say that we don't have evidence of their safety, so we will not allow this one. So sometimes they will ask you that if the patient has already delivered at home, what is the chance that she will be transferred to the hospital? Then the chance is 10%. Though she had a previous successful home birth, but again 10% chance that she will be transferred to the hospital for any emergency like that. So then if in a layman's person language, if we talk that why we want to deliver the patient to the hospital, like if you have concerns about the heartbeat of the fetus, or mother becomes excessively exhausted and she says that now I cannot cope up with the pain or stress, and or there are any indications for instrumental delivery, then you will say I will transfer patient and follow principles of safe transfer which are laid down by NICE. Okay? You don't have to go into the details. Okay? Then other causes for shifting can be like there is cord collapse, there is fetal distress, there is high BP, or labor dystocia. So in all of these conditions, you will have to transfer your patient to the obstetric unit. Okay? So that is the point. So you should mention all of these points. So this patient should have been induced before. Okay. So she has not. So and you will need to inform the obstetrician also. So that is the point. And then you should tell her she will have concerns that if you will deliver me by in the hospital, then you will deliver me by cesarean section. She will say that why are you saying so? Then she will tell you that all of my friends who went to the hospital, they have ended up having cesarean sections. Then you should tell her that we are not sure that why exactly they had a cesarean section, but we will do cesarean section only because of obstetric indications. That is the point. Okay. So you will document all information, and then you will give her full information, give her some time, and make a plan, and then execute the plan. So you will involve her in decision making. So that's all you need to mention here. So any other problem, any other suggestion you have?
No.
And then another thing, which I even I before I forget this one, she's 42, right? So she is at high chance of having a dysfunctional liver. What about the chance of having PPH? Again,
She's
that
at a
is
high risk of PPH.
high risk. Rather, that is the most common complication of aged mothers, right, in this population. So she needs to be inside hospital because maybe if the PPH occurs and then it will be a frightening experience. So we will have to ship her to the hospital immediately. So all of these things, like you're telling all of these things to your patients in your routine practice, isn't it so? Okay, that's all. So this next one is not exactly a station, but in the teaching station, they can always ask you that what is this document and what will you like to do. Why I said that not very fond of this station because you people know about the this one partograph.
Partogram.
And I think I don't remember that we discussed it when we were talking about the teaching station, or did we? Can you
No,
recall?
no, no, we're not.
Okay then. So let's call Dr. Vasavi for this station, and then she will take 2 minutes and she will give us a teaching session on this partograph. That what are the benefits, what are the problems, why do we want to keep one, and what important information it can give us. Okay. Okay, Dr. Vasavi, are you there?
Yes.
Okay. So your time starts now. You know why I keep telling you about the time? Because it's very important for you. And though you will be knowing tons and tons of information, but if you are unable to give that information within 10 minutes, then you are gone. Okay. Then you will lose marks.
This conference will now be recorded.
Okay. You can start.
Hello, my name is Vasavi. I'm ST5, and you are?
Yeah, I'm Lily. I'm here. I'm in the foundation year.
Nice to meet you.
Thank you.
How is your training going so far?
Yeah, I'm enjoying it. I'm new at it, but I must say that I'm enjoying it. I'm seeing new things. Yeah, interesting. So I'm learning a lot.
Okay, yes, nice to hear that. And I understand you want to know about the partogram today.
Yeah, that's true. Yes.
Okay. Have you got to fill your partogram anytime on the labor ward so far?
Not yet. That's why I'm here because I have seen the residents doing it all the time. I've seen the STs doing it all the time, but I don't understand. So especially these two oblique lines, they confuse me a lot.
Okay.
I don't know what exactly is
Yeah.
this one, but they will come up every now and then, like they are coming every 4 hours and then they're assessing the patient and making some circles. I understand that they are doing something that how the patient is progressing, but I don't fully understand it.
Okay. Yeah. Just we will discuss about the partogram today, so that from the next time you will be able to do it. And if you have any doubts, I'm here to clarify it, and I will give you information about where to read about the partogram also.
That will be so great.
So
Thank you so much.
yeah, uh, uh, we have two pages, right? The first one is about the vital information. This identification of the patient. So we have this name, what gravida is she, what para, and the hospital number, right? And what time, like the date of admission, and when she ruptured her membranes. That is the whole identification of the patient. And then we have the vitals of the patient: her temperature, her blood pressure, pulse rate, and how often she's getting the contractions. And if you see the columns with me, I will all these columns we would be filling it. So depending on if we say right, if she's getting regular contractions, how many contractions and 10 minutes that she's getting, we'll be filling up the block in that. And if she started on augmentation with oxytocin, we will see like at what unit, how much units of oxytocin she started and how we're increasing. That information we'll get in the block of oxytocin, and whether she's getting any fluids, and her urine, whether she has any ketones or protein in the urine. that usually these vitals would be checked for normal laborers every hour in case of normal laboring women.
Okay.
Uh, and this we will get all the information by seeing the chart. We will get all the information in one page. So how
Okay.
she'd be progressing and what is her condition, whether she is dehydrated and or what is her vital status and the second part is the important part. So we could see when she started. Um,
Yeah.
And also from the first page, we could identify any high risk factors, like if the temperature is high, like if it's more than two readings more than 37.5 or one reading more than 38, we could suspect it is chorioamnitis. Or if if any variations in the blood pressure, if she is like a hypotensive with tachycardia, we should suspect and we could start IV fluid resuscitation. And if she's getting less contractions, then we could increase the dose of the syntocinon depending on to get at least 4 contractions in 10 minutes. So this information is that if she has ketones, we could increase the fluids.
So, Doc, who is going to fill this part? Do we have to fill the both sides of the form?
Usually, this would be filled by the midwives who would be monitoring the patient.
Okay.
So this would fill by the midwives usually.
Yeah. Okay.
And the next part is the next part of the graph is shows that how she's progressing in labor. So we will start the partogram when she's in active labor. That means when she at least like when we start observing her and when she's 4 centimeters dilated, then she should be in active labor with regular contractions. So from that time, we have 2 lines. We will observe the vaginal examination. We will do every 4 hours to see, like here, if you're seeing it with me, about the 4 centimeters dilatation. So next 4 hours, and we will see, and we will check what is the dilatation, and put a dot over this, and we'll join the dots to see how, in what way the labor is progressing. And every four hours, we will do vaginal examination.
Okay.
So usually it should be the progress should be at least like a normally it is 1 centimeter, but we allow it as it's 2 centimeters. At least in 4 hours is a normal cervical dilatation.
Okay.
If it is less than that, then if it comes between the alert line and action line, so they have to do intervention. It means that labor is not progressing good, right? The progress is slow. If it falls between the cervical dilatation and dots, joining the dots makes a line. So if it falls between alert and action line, that means the progress is slow. Then we have to do the intervention. So far, am I clear so far?
Yeah, I'm with you. Actually, it's very
Yeah.
fascinating.
All right. So and then what are the interventions we are supposed to do if the progress is slow?
Okay.
We could rupture the membranes and right. Sometimes the rupturing of the membranes will make the contractions strong and they will progress. And even the rupture of membranes is not helping, then we will start the like oxytocin infusion for the labor um, uh, to progress faster.
Okay.
And
So, what is the benefit of
so
using this document?
So we could, it's how we could detect the progress of, it's a graphic representation of the labor. So we could identify any slow progress of labor and we could intervene. So we could intervene using syntocinon, or we could, if we could assess the delivery by using the forceps if there is no progress, if there is no descent after full dilatation, and for for about 2 hours. Then we could do the assisted delivery using the instrument, or we could do cesarean section, depending.
So are
So
there
this
any,
mainly,
sorry, continue, please. Please go ahead.
yeah. So from this partogram, we would see the progress of the labor, and early interventions is possible, avoiding the complications.
Okay, so that is the benefit. Thank you very much. It was very comprehensive. So anything else you would like to tell me? Does it,
I will give you
yeah, sorry. Does it have any role
this
in
will
the intervention of doctors? Protects us against anything?
Yeah, this is a medical legal document. So we could this is helpful, that this reduces the actually medical legal issues, why the intervention was taken, and also this reduces the cesarean section rates, um, if correctly applied.
Okay, okay, that's great. So we use partogram all the time, right? And you have covered most of the points. That's very good. So that is the point, okay? So that is the point. Okay. Anything else? Okay. So you have covered most of the points. Just yeah, you were justified in saying that how they should progress. You should tell them, and then you should say that it will give you some idea that labor is being dysfunctional, and we need to take up some other interventions. Okay, so you should mention all of these points. Okay? That is the point. So well done. Just a quick recap. So when you are starting something, first of all, we will start with identifying the subject. This program, they can ask you in several ways. Like they can ask you to comment on that, and then sometimes like some complication has occurred, so they will bring in this partogram as an evidence, that they will ask you that what do you think, what was wrong in this partogram, why things were not picked up, so are there any red flag things, so you will comment on that. Or they can tell you to teach to a junior, then that how they will uh, read it and how they will fill it. Okay, that is the point. So you should say that partogram, it is also called partograph, it is a composite graphical record of the key data, like we are keeping record of both mother and the baby during labor. Okay? So we monitor that at what time what happened, and all of this information you were justified in telling that it is on one sheet, so at a glance you can see that how she is progressing. And the important points are statistics like how much is the cervical dilatation, how much is the fetal heart rate, and duration of labor, and vital signs. So it is very important tool for maintaining patient safety also. So basically, we fill a partogram because it gives us an accurate record of the progress of labor, so that any delay or deviation from the normal, it may be detected quickly and treated. So it is intended to provide an accurate record of the progress of labor. So as still it is an in the standard care we use it. So regarding the components, like you said that it will give you all information on the patient identification, then it will tell you about the fetal heart rate, and that membranes have opened, or they are intact, or they have opened, and at what time they opened. So if the membranes are intact, you will write down an I, and if the membranes they're like ARM has been done, you will mention that one, that when ARM has been done. And if you see meconium, then you will write down the letter M on it. Okay? So basically, we are monitoring two parameters, that what is the rate of dilatation of the cervix and what is the rate of descent of the head of the baby. Okay? And then the vital signs of the patient, you were justified in telling that they are taken by the patient and they by the nurse, and she will fill in that data. And it is also very helpful if we are using oxytocin for augmentation of the labor, because the patient is already in labor when when they are in active labor, then you are starting to use it. So it will tell us that how much syntocinon has gone into the system, what is the rate, and what is how the mother is responding to it. So every time she is passing urine, this is also mentioned here, and the temperature is also mentioned here. But all of this data is filled in by the midwife. Then what are the advantages? Provides information on single sheet of paper at a glance, crystal clear, simple line. This should be part of your standard practice. Then early prediction of deviation from normal progress of labor. Improvement in maternal morbidity, perinatal morbidity, and mortality. But nothing is perfect in the medical world. What are the limitations? Photograph, it requires a skilled healthcare worker who can fill and interpret the photograph. And then some studies, they have shown that no evidence that photograph use is detrimental to outcomes. It is not going to deteriorate the condition, it is going to improve the situation. Often paper photograph and the equipment required to complete are not available in the low resource settings. So usually in the midwife-led units or in the obstetric units, this document is used. So then it can be used efficiently, it's easy to use, and then the information contained in it is all that we keep in the birth notes. It can be kept in the record, and it is recommended by the NICE also that it improves patient safety, so it should be kept in the patient's record. So digital photographs are also available, but still we are using these paper version. Okay, advantages that we can mitigate human errors. WHO says that the protocol, it is different in the different recordings in the settings. When you are using this electronic paper graph, it can remind the staff and nurse to enter labor vitals in case they forget the standard protocol in some cases. So they will keep getting the prompts that fill in that data. So you are not ignoring your patient at any time. So then this, because of this partogram, it will increase accountability also, because a legal document is there that if something was wrong, then why a standard document was there, so they can always question you that why these interventions were not done. If it was not safe to continue normal labor, then why did we continue using that? Yeah, that is the point. So then it is easily available, it is very easy to use. So all of these are benefits and very important tool in improving patient safety. That's all you need to tell them. So if anything falls outside this line, then it means that labor is dysfunctional, or there is unnecessarily increased danger for the risk for the mother. So we need to do interventions. That's okay. So then you can also say that if we are using partograph, then this is a holistic approach which is adopted, and we can communicate all the effect that how the everything what is happening to the patient. We can mention that one, and then it is a safe, increases safety for the caregiver and also for the patient also. That's all we need to do. So then a couple of other stations like CTG thing we have done, so you know that how we will read the CTG and how you will plan the delivery. Okay, so we talked about the normal CTGs in the previous exams also, in the previous stations also. Let's go to this one. Okay, Dr. Amita, next station is for you, because you know in the interpartum period you can have several emergencies like cord prolapse, undiagnosed breech, shoulder dystocia. Okay, so you should be ready for these things. Those issues like third and fourth degree perineal tears, PPH, all of these things we will do in the module on postpartum care. That is also very important, especially you need to know about the postpartum perinatal mental health issues. Okay, that's all you need to know. So Dr. Amita, this next station is for you. You will take 2 minutes, then we will talk about this case. So when our guest visitors, nobody has volunteered, so I think then you people can do these stations. So, Dr. Amita, please take 2 minutes and then we'll talk about this case.
This conference will now be recorded.
Okay, so this is a structured discussion task. Can we start? Hello. Hi, Dr. Amita, are you there?
Yes, I'm there. I had unmuted. I'm there.
Okay, okay, that's fine. Welcome. So can we start this one? This is a structured
Yeah.
discussion, as you can see, right? Communication with colleagues and that one. Dr. Amita,
Yes. Should I begin?
yeah, I asked you like 2 minutes ago to start.
Oh, okay, okay, okay. I thought we were waiting for 2 minutes.
That's
Okay.
fine. No,
Now,
no worry.
now we will be talking about artificial rupture of membrane. Now, usually artificial rupture of membrane is a procedure which is done in cases to augment labor or to induce labor also at times.
Okay,
And uh, 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 and whenever we are doing artificial of rupture of membrane, we should first examine the general condition of the patient, the abdominal examination, the pelvic examination, and after doing the artificial rupture of membrane, we should hear the fetal heart rate for 1 minute and look at the color of the liquor. And before we perform an artificial rupture of membrane, the station of the head has to be taken, at what station the head is. Mm. Sometimes when the head is not engaged or it is high floating, in that case, we should be very careful that while performing the uh, rupture of membrane, because there is a high risk of cord prolapse. This is an obstetrical emergency and the incidence of cord prolapse is 0.1%. Since it's an obstetrical emergency, we should call for help. A midwife should be called, a senior midwife who can arrange for things. Then a senior obstetrician should be there. Then a pediatrician should be there to take care of the baby, and there should be a senior anesthetic also, because we would be requiring uh, uh, help of all these things and additional staff if required.
okay,
Uh, if cord prolapse occurs, first we will first examine the per abdomen and see what is the condition of the fetal heart rate, if the fetal heart rate is present or absent. In case the fetal heart rate is present, we would debrief the situation to the mother and ask her not to push or bear down, and we would we will try to remove the pressure on the cord, because as soon as the cord comes out and it is exposed to the environment, there occurs vasoconstriction, which causes hypoxia and hypotension of the baby, which can lead to fetal distress. And there is a high incidence of uh, fetal demise also. So we have to relieve the woman once we have made the diagnosis that this is a cord prolapse. We should, and the fetal heart rate is there. We should do a per vaginal examination to know the station, dilatation, and uh, uh, whether the vaginal delivery is imminent. In case if the mother is fully dilated, then we can perform an instrumental delivery if we feel that the delivery is imminent, because we have to expedite the delivery. In case we cannot, the she's not fully dilated or imminent delivery is not possible, in that case we have to transfer the mother to the operation theater and perform an urgent cesarean section, category 1. But before we perform the cesarean section, we should ask the mother to be in the left lateral position, and uh, uh, the hip of the mother has to be elevated, and either she should be in the exaggerated Sims position, exaggerated Tendenberg position, that is the hip has to be raised, or a Sims position in lateral position, so, or the knee chest position. We should not manipulate with the uh, cord, and try to we should relieve the compression of the presenting part on the cord. We can even fill the bladder with about 500 to 700 ml of water of normal saline, so that there is no once we have the presenting part is off the cord, then we can fill the bladder also. And in case the patient has to be transferred from home to the hospital, then the best method would be asking the patient to be on her side, uh, on her side, and a pillow should be placed under the hip, and we would elevate the presenting part so that the cord is not compressed. And we should perform the cesarean section at the earliest. The neonatologist uh, should be there, uh, and after the delivery of the baby, cord blood should be sent for pH, and we should take care in case if there are additional signs of sepsis, then antibiotic has to be given, since this would be an emergency cesarean section. So uh, thrombo prophylaxis has to be given, and we should monitor the baby and the mother and debrief the condition to the mother, and incident report has to be given, and all the documentation has to be done, and incident reporting has to be done. Anything else you would like to know from me? Hello, am I audible?
Yeah. Are there any risk? What are the risk management issues here?
uh, in this case we have to do a risk management appraisal, what went wrong, how it was happening. This is not to blame somebody, but to make improvement in the condition and improvement in the care of the patients, that what things could be done to prevent cord prolapse. Was artificial rupture of membrane done in a high floating head, uh, and were all precautions taken? So that has to be reviewed. Why was artificial rupture of membrane done, and what was the station at the time?
Yeah, that's important. So you would like to stop here?
Yes, anything more you want to ask me, I can tell you.
That's
And I will give you certain leaflets also. I will give you certain websites also, which would be explaining you about in detail about and will give you some patient information leaflet also.
That you will say if you have a patient, right? Or you have a junior for whom you are carrying out this teaching station. But here we were dealing
So
with a structured discussion. Okay, so like I have told you that
I
when
will
you
give
are
you
going through the
some
circuits,
websites and some
yeah,
green top guidelines regarding this.
that's great. That would be great. So when you are going through the circuit, you will write down the stations and you will write down that what type of task it is. Patient simulated task, PST, right? Structured discussion, write down ST so that you will not lose the focus. And they will not give you a simple case that just comment on this one. They will just give you a scenario. Okay, that this thing happened in the last week on our delivery suite. So let's analyze it. Let's see that who was at fault. So you are not going to blame anyone. It can happen anywhere, anytime. Real incidence is very low, like zero point 0.1, um, zero point 0.01 to zero point 0.06. It is 1% in cases of breach. It can happen. You should know about the definition. Sometimes they can just show you an ultrasound photo image where you will see that there is cord presentation, but still it has not prolapsed. So you will admit that patient or you will give him some counseling on that. So well done. You have covered all points. Just a quick recap. Okay. So even if you know something comes to your mind and you want to share, you can always send me an email or you can contact me on WhatsApp. I'll be very happy to answer your questions. Okay. First step, summon help. OB and mid, and then when they were asking you that how you are going to organize the care, so you will say, I will call for help, I will inform anesthetist, I will inform neonatologist and my immediate senior. Okay? Be very specific. Whom you are calling? Okay. Why, if they are asking you, you will explain. Otherwise, you will just say that who is going to be on your team. Someone help obstetric and midwifery team, anesthetist, theatre staff, neonatal doctors, and scribe. Just tell them very clearly what has happened. Confirm the presence of a fetal heartbeat using ultrasound and apply a CTG to monitor the fetal heart, because if it is showing some abnormalities, you are going for CAT1 CS. No abnormalities, then you are going for CAT2 CS. By the way, CAT1 within 30 minutes, CAT2 within 65 minutes. So still you will not have like this facility that you can wait for like 12 hours. No, you have to do something within 1 hour and 15 minutes. That is the last limit. So if the fetus is alive and of viable gestation, then management consists of reducing the risk of cord compression and rapid delivery. Avoid handling loops of the cord to prevent vasospasm. Why vasospasm should be prevented? Because it will expedite ischemia, fetal distress. Manually elevate the presenting part of the cord. Fill the bladder with 500 to 700 ml normal saline with a blood-giving set and a Foley's catheter. Place the women in a knee chest position or Trendelenburg position. Tocolysis is indicated if your patient is contracting actively and you are preparing for the CS delivery. So terbutaline 0.25 mg subcutaneously, which is beta symptomatic. It can be employed to reduce contractions, especially in the presence of a fetal heartbeat abnormality while you are preparing for the CS. Deliver the fetus. If this is achievable vaginally, then an instrumental delivery is usually appropriate and you can apply even at 9 centimeter. Mostly, however, delivery will be by cesarean section. If there is a suspicious or pathological fetal heart rate pattern, then a CAT1 CS should be performed. Delivery should be within 30 minutes. Verbal consent will suffice. If the fetal heart rate is abnormal, if the fetal heart rate is normal, then a category 2 C-section is appropriate and regional anesthesia can be considered. Ensure a pediatrician team is present at delivery as aggressive neonatal resuscitation may be required. Document the delivery carefully, including timing and cord gas analysis. Fully debrief the family after the event because it is a frightening experience. So you need to tell the family what exactly has happened and how they can cope with the stress and how the baby is doing now. So that's all we need to mention there. Okay, and how you can the clinical risk management issues are that you should everyone should know about card prolapse. ARM should be done only when the head is fully applied and patient is fit to have a normal delivery. And so if the head is high or floating or you are uncertain of the presentation, never do that. Okay? All of these things, simple things, but these are important. Skill drills should be arranged. Make it a habit to say skill drills. So regarding this, so well done. That one is fine. So SBAR tool, I think we have done that when we were doing this teaching station. So what is this one? Baby was stuck, so shoulder dystocia, no need for that one. We have done that one also in the teaching. So next one. This is your Dr. Vasani. Thank you, Dr. Amita. That was good. So again, a structured discussion. Some of the stations we won't be able to finish today, but they are important, like prioritizations and breach presentation. So we will do that in the next session. We will be doing this postpartum care and the neonatal issues. So what type of hematomas your baby can have, and instrumental delivery and the complications. Those things I plan to cover in the next session. But for this session, we have another remaining station. Dr. Vasavi, are you there? Hello, doctor. Can't see her. Yeah, here you are. What happened? Next station is for you. Dr. Vasavi, are you there?
Give some time.
Yeah, it's your turn.
This conference will now be recorded.
Okay.
Um,
So you are doing a
um,
teaching station on PET for your juniors, okay? And why
okay.
which info has triggered it? Because last week we had a paper where ST2 admitted this patient. Debra 2 para 1 35 weeks of gestation, and she was admitted, and the BP was like this one. And then she was admitted to ST2. Then you guys managed that. So what you can teach your juniors on care of this PET. Let's start. Your time
Okay.
starts now.
What is the full form of PET?
Preeclamptic toxemia of pregnancy.
Thank you.
We had it. Okay, Dr. Vasavi,
Yes, I'm ready, doctors.
start please.
Um, so I'll be conducting a session on the management of preeclamptic toxemia. So it would be conducted at the time which is convenient for all the staff and in the non-working hours, and it would be conducted in the conference room by the hospital, and I will send the information to all the doctors in the uh, um, um, in the community health center, and all the junior doctors and all the and obstetric consultant and registrars, and also including the midwives. Um, I will send the email for the attendance of the session. And the session will involve mainly discussing about the index case which has happened a few days ago regarding the management of the lady with preeclamptic toxemia, and which who needed admission to the HDU unit. And there will be uh, uh, no blaming of of any of the persons involved. It would be mainly discussing the events and what were done well and what would have been improved to improve the care in the future. And also involvement of both the juniors and the seniors. Juniors to learn learn from the mistakes, and the seniors to address the management issues. And a-
So what
and
information will yeah.
right um, this
I mean, what will be the
information.
content of what will be the content of your talk?
Okay.
this is mainly involving the management of the like preeclamptic toxemia patients. So this information involves how uh, 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 how often how often these patients needs to be monitored, and at what gestational they would be admitted, at what blood pressure range, and so if they have 140/90 blood pressure, and with protein in the urine, all cases of the preeclamptic toxemia needs to be admitted, and also they should be started on the antihypertensive medication, and they should have um, um, investigations to full blood count, renal and UNDs needs to be done, and also how often their blood pressures needs to be monitored, and monitoring of the baby. And also in cases of emergencies, when they get admitted, what are the things we need to do, like when they get admitted with a very high blood pressure. First essential thing is like informing the seniors, and the treatment of the high blood pressure, at the same time putting an IV access, and it involves drawing the bloods for full blood count, UNDs, and starting her magnesium sulfate infusion, loading and maintenance dose, loading dose of um, uh, 4 grams of 20%, um, over a period of 5 minutes, and then followed by the maintenance dose of 1 gram per hour. So to prevent the eclampsia, and also controlling the blood pressure using the levodopa infusion, starting at the 20 milligrams boluses. And during the process, her blood pressure needs to be monitored continuously, uh, continuously with the charting every 15 minutes, and if she's on Maxwell for every hour, or monitoring of her pulse rate, blood pressure, urine output, and reflexes, and oxygen saturation, so needs to be monitored, and her fluid restriction, so that she would get only 80 ml per hour, and because she was only 35 weeks, she might need early delivery. So, involving using the steroids for the um, uh, fetal lung maturation, and involving the pediatricians, informing the pediatricians, because the baby might need early delivery. Um, and um, induction of labor if her blood pressure is not well controlled.
Okay.
Do I need to speak about eclampsia management? Or?
Yeah, you should say, because you still have like 3-4 minutes. So you should talk a bit about health and about eclampsia, because these are the complications which you are trying to avoid at this level. Okay. You are
Okay,
preventing your
yes.
patient to develop this full-blown eclampsia. So examiner is
Yes.
not going to prompt you. It's your job to keep your time,
Yes.
okay, and observe these time limits and give quality information like that.
So the complications which are likely to arise in case of a severe preeclampsia is, one of the complications is the HELP syndrome, that is the hemolysis and low platelets, elevated liver enzymes. So we need to observe, and we need to check with the blood results, and following up at the during this results every 4 hours. But the early delivery is the management of HELP syndrome. and so if the platelets are very low, and avoid intramuscular injections, and um, avoid avoid if it's in the range of less than 50, less than 80, avoid epidural and spinal anesthesias.
Right.
And cross match for the platelets, and also um,
Only
and
group and C. Only group and C and coags. Okay. Coagulation profile and group and C. You will ask if, because cross matching means that someone is bleeding, right? You will need to collect blood. So we don't need that right now. Maybe your patient is relatively stable, then you don't have to do this intervention. Okay. Anything else you would like to add? Because the fetal monitoring, you didn't say anything about that. The route of delivery, mention those points also. Okay.
yes,
You can say them
yeah,
now.
maybe
Yes.
is for the fetal monitoring in the antenatal period. She would be monitored with antenatal period with treating the preeclampsia. Then she would be monitored with fetal growths and umbilical artery Dopplers. But in case of the acute situations, we'll be monitoring uh, this CTG. And
Okay. Yeah. Yes, that's great. You will monitor the baby by CTG, and during the antenatal period, you will carry out the growth scans and appropriate care. And the hypertensives, you will have to see them every 1 to 2 weeks. Diabetics, hypertensives, cardiac disease, you can always call them in the clinic every 1 to 2 weeks. Okay, well done. Actually, this PET, preeclampsia, this is quite a complicated topic. I understand that in all parts of the world, because you all are working in different parts of the world, but the drills are going to be the same, right? But when you have to explain it to others, then it can be quite challenging. So you were justified when your start was very good. You want to say something else, or I can give
no, no.
okay,
Yeah, yes.
yeah, that was wonderful. So then you have told them about the reliable resources, and then you should say that if you have some other problems or any concerns, I will welcome you. One thing was missing, that you didn't check that what is their pre-existing level of knowledge, right? How much do they know? Okay, so always establish. That's how you can start. So can anyone tell me about PT? What do you understand by it, like that? Okay. We just wait for like 10 seconds and then you will start. Even if you have to deliver a lecture in your routine life, which you know that if you are working in a good hospital, you will always have to give talks every 2 3 weeks. So you should ask. So check the background knowledge and then proceed. So well done. You have mentioned all the points. Just a quick recap. Whenever you are going to teach something to the juniors, there are W questions, and one question is how. What happened, where, why it occurs, when these problems occur, and then how you can manage them. So what are more important? Who is involved in such cases? Okay, so all 5 6 W's, and the seventh one, how. So you need to, so this is for your sake of convenience. So you can say that preeclampsia, this is a multi-organ disease process characterized by hypertension and either proteinuria or severe features of preeclampsia. Then you can say that proteinuria is not in the diagnostic criteria, but it will tell you that patient has end organ damage. To meet that diagnostic criteria for preeclampsia, systolic BP must be 140 or more, or diastolic should be 90 or more on at least 2 occasions and no less than 4 hours apart. Okay, that is one thing. But if the BP is like 150 by 100, 150 by 160 by 110, then you don't have to take 2 readings. Then you are going to decide on the basis of 1 reading only. Okay. So pay attention to the numbers they have given you in the question. How it develops, there are different theories. If you have like you just even you say one line, you forget rest of the content, but you mention just one line, you are good, because the examiner is just going to check the boxes, and they will say that she has mentioned this point about pathophysiology. Genetic predisposition, maternal, paternal, homophilias, immunological phenomenon, abnormal placental implantation, like defects in the trophoblast and the spiral arteries, because basically the trophoblast will not develop deep enough to reach our arcuate arteries, so the nutrients and the BP and the blood, it will not go properly, so more chance of having vasoconstriction. There can be vascular endothelial damage, oxidative stress, and angiogenic factors are also involved. Anything you remember out of this, that's fine. Okay, so these notes will be available on your web page. Don't worry about it. Don't write down anything. Then you will see that does she have any risk factors like family history, first generation relative, so 3 times increased risk, nulliparous 3 times higher risk, morbid obesity like more than 40, 1.6 times higher risk, so you 1.5 times higher risk, multiple pregnancies, risk increases 3 folds, PET in the previous pregnancy, then you know that if it required delivery before 28 completed weeks of pregnancy, then her chance of developing PET is 1 in 2. If she delivered before 34 weeks due to uncontrolled blood pressure, then her chance of having PET in the next pregnancy is um, 1 in 4, 25%. So, but the risk will increase 7 folds. Then, if they have any pre-existing disease like chronic hypertension, chronic renal disease, any diagnosis of SLE or APLS, then elevated body mass index, then it will increase the risk 2 times. So if she has diabetes, which can be pre-existing, not in GDM, but pre-existing diabetes, then the risk will increase 3 folds. Similarly, if you have a woman who is in her 40s and she is pregnant, then again her risk will increase 3 fold, 2 fold increased risk of sorry, 2 fold increased risk of PET, 3 fold increased risk of GDM, and 9 folds increased risk of VTE. Both are true for obese people and also for mothers in advanced maternal age. So what recommended management, maternal and fetal findings like at 37 weeks or more of gestation, or 37 weeks and less than that of like it is 36 weeks. The patient comes to you with in labor or rupture of membranes, or there are abnormal maternal-fetal test results, ultrasound estimates of the fetal weight less than fifth percentile, suspected abruptio. If I, because you know all of these complications are more common in PET. None of these things is present, then we are going to do maternal evaluation only in the OPD basis, twice weekly, and fetal evaluation with preeclampsia twice weekly, non-stress test, CTG, and ultrasound evaluation. With gestational hypertension, you will have to do these tests every week. So if she is then you have to see that are there any features that concern you, like history of premature rupture of membranes, preterm labor, or fetus has developed some abnormalities, some doctors, then if that is the point, then you will have to label that. If any of these things is positive in the patient, so again, she merits induction of labor. So the fetal outcome, it will not vary much between, it will not improve much between 34 to 37 weeks of pregnancy. So that is the ideal time when you should think about delivering this patient. And the last limit to deliver this PET patient is 37 weeks. If systolic BP is more of 110, at least 2 occasions, 4 parts, then you will say that this is severe PET. Then if they have progressive renal insufficiency, like serum creatinine is more than 1.1, or there are like your patient is complaining of other signs of meningeal irritation like cerebral or visual disturbances, any evidence of pulmonary edema, impaired liver function test like transaminases. This is, you know, the going for the HELP syndrome. Right upper quadrant pain or epigastric pain, and the thrombocytopenia when the counts are less than 100,000. So that will be your HELP syndrome. So how do we manage severe PET? So bed rest with Caesar precaution. So you have to see how are the vital signs, BP, pulse, respiration, and deep tendon reflexes, they are intact or not, and neurologic checks every 15 minutes until patient is stable. If they give you someone who is in the crisis now, you have admitted her to the HDU, accurate record of intake and output, Foley's catheter needed. And then IV lactated ringgit can be given at 50 to 125 ml per hour, but on average you should give like 80 ml, and the output urine output should be 30 to 40. Okay, then the total intake, it should not exceed 125 ml per hour or 3000 ml per day. External monitor for contractions and fetal heart rate. Labs, dipstick urine for proteins on admission, and if not needed if we have definitive finding of severe features. So 24-hour urine protein is not indicated anymore. Regarding the medications, when you talk about giving the control, the first drug to be used, you should say that if the patient is at presenting with this high blood pressure, then we will start with magnesium sulfate. So sometimes they can ask you in the Viva that if the patient has renal disease, then would you like to give her Excel? You will say yes, we will give, but we will decrease the dose by half. You will give her half ml to 1 gram, half gram to 1 gram per hour. So justified in telling us about the dose of Smexel, but labetalol, you should say that you will give labetalol if your patient has no contraindications to the use of labetalol. You know about them, right? And if it is not controlled by one drug, then you will have to add other drugs like nifedipine, or the patient shows signs of magnesium toxicity, you will give them calcium glucose. So to avoid respiratory distress. So what monitoring is required if you have given Maxell? You have to see reflexes, mental status of mother, respiratory status. She's after starting this Maxell, how much is the urine output? So magnesium therapeutic levels are 4 to 8 milligrams per deciliter. Pay attention to milligrams. Okay. So if it increases, then you will, some books they will mention 4 to 7, but 4 to 8 is fine. Okay. You know the criteria for health that we need to pay attention that she's not going into the Hunt syndrome like abnormal peripheral blood smear, which means that blood cells are broken down like histiocytes, blood cells, helmet cells, and serum bilirubin greater than or equal to 1. LDH greater than 600. LDH because there is intravascular hemolysis, elevated liver enzymes twice the upper limit, platelet counts less than 100,000. So the same, admit to the HDU, premature baby less than 34 weeks, corticosteroids, Maxell, ultrasound, see the fetal heart, Dopplers, and the lab test, biochemical PET bloods. You will use the word, we will carry out PET bloods. So first of all, you are going to stabilize the mother, and then you will deliver the baby. In most of the cases, you can offer expectant management, but in these circumstances, like there is eclampsia, there is pulmonary edema, DIC, uncontrolled severe hypertension, dead baby, abnormal fetal test results, abruptly presently intrapartum fetal demise. So expectant management is not an option. So if the baby is alive, then you will give corticosteroids, and you can deliver the baby depending upon the maternal condition. If mother is BP is not being controlled, then you will have to give cover and expedite delivery. Otherwise, you can wait. So if the patient has like resistant symptoms, there is evidence of IUGR, severe oligohydramnias, and reverse and diastolic flow, and then labor or premature rupture of the membranes and significant renal dysfunction, that all of these are present or no. If they are present, then you need to expedite delivery. If they are not present, then you can offer expectant management. So HDU admission, care of both mother and the baby, then fetal viability, then you are going to deliver. Inpatient only and stop Mexel, and then daily maternal fetal test, vital signs, symptoms, and blood tests, and then oral antihypertensive therapy can be given. So if we cannot do this one, then what we have to do, that we have reached this, we will go to the 34 weeks of delivery, and we will see that does she have any new reassessment. He needs any, she has developed any other abnormality to expectant management, then we will have to expedite delivery. Rest of the management is going to be the same. So I think we can stop here. Some important stations like VBAC, uterine rupture, uterine inversion, PPH, all of these things we are going to discuss in the next session. So any questions?